Women and Children with HIV/AIDS. This course is designed as an introduction to the complex issues associated with HIV/AIDS among women and children in the United States. It is intended to provide participants with a better understanding of the prevalence, nature, and impact of HIV/AIDS on this population, as well as treatment and intervention implications. A complete reference list to accompany this training is available for download on the National AIA Resource Center's website at aia.berkeley.edu. Overview. HIV/AIDS presents a significant health crisis for a segment of American women and their children. In the early years of the epidemic, relatively few women and female adolescents were diagnosed with HIV infection and AIDS. Today, women, especially women of color, represent an increasing proportion of new diagnoses and deaths. Because many women with HIV infection are mothers, numerous children are also infected or affected by HIV. Consequently, it has become a family illness. This training will provide information on the prevalence and presentation of HIV/AIDS in women and children. It will also address medical, psychosocial, parenting, and legal issues associated with the disease, and present types of interventions to address the complex needs of women and children affected by HIV/AIDS. Let's consider HIV/AIDS prevalence in families. To estimate the prevalence of HIV, the Centers for Disease Control and Prevention, or CDC, maintains a surveillance system that collects reported cases of HIV and AIDS from all U.S. states and territories. According to these data, more than 1 million people are estimated to be living with HIV/AIDS, and approximately 25% of them are women. The CDC also reports that the number of females living with HIV/AIDS has increased significantly over the last decade. HIV used to be a condition that primarily impacted men, particularly men who had sex with other men. However, beginning in the 1990s, an increasing number of women contracted HIV, primarily through intravenous drug use. Currently, the majority of women with HIV are infected during sexual intercourse with an HIV-infected man, while the spread of HIV among women due to injection drug use has declined in recent years. Rates of AIDS among women of color. Women of color, especially African Americans and Hispanics, are disproportionately affected by this epidemic. African Americans make up the majority of reported AIDS diagnoses among women, despite their minority status in the U.S. population as a whole. Moreover, the number of AIDS cases is higher among African American women than for women of all other racial ethnic groups combined. Although rates among Hispanics are lower than African Americans, the Hispanic population also contracts the disease at a disproportionately higher rate than whites. Childbearing and mother-to-child transmission. With medical advances, women with HIV are living longer and healthier lives. Despite the fact that their life expectancy is much lower than that of non-infected women, HIV-infected women live, on average, 20 to 24 years after their diagnosis. The vast majority of women living with HIV/AIDS are of childbearing age and have a greater range of reproductive options than in the past. Many of these women desire and take steps to have children, while other women experience unplanned pregnancies. In fact, in a nationally representative sample, 28% of HIV-infected adults, representing 35,000 families, had children. There is a risk that an HIV-infected pregnant woman will pass on the virus to her child. In fact, mother-to-child transmission is the primary method by which the disease infects children under 13, and it can occur at any one of three stages: during pregnancy, during labor and delivery, or after birth via breastfeeding. Transmission during labor and delivery is the most common means of infection. Without treatment, transmission of HIV occurs in 20 to 45% of pregnancies. However, mother-to-child transmission rates have been reduced to less than 2% with the use of highly active antiretroviral therapy, or HAART, during pregnancy. IV AZT during labor and delivery, cesarean delivery when appropriate, AZT administered to the newborn for 6 weeks after birth, and by avoiding breastfeeding. HIV prevalence among children less than 13 years of age. Now that mother-to-child transmission can be effectively prevented, the incidence of HIV in American children has dropped significantly from previous rates in the 1990s. In addition, effective antiretroviral therapy has enabled many perinatally infected children to survive into adulthood. Because the vast majority of children who do contract the disease do so through perinatal transmission, HIV/AIDS in children closely resembles that of women. That is, children of color, especially African American and Hispanic children, are overrepresented in the ranks of children who are HIV infected. Let's look at HIV/AIDS in a medical context. HIV testing. The CDC recommends offering HIV screening for patients in all healthcare settings and encourages people at high risk for infection to be screened for HIV at least annually. They advocate making voluntary HIV testing a routine part of medical care, much like screenings offered for other treatable conditions. The HIV screening tests available are relatively reliable, inexpensive, and non-invasive. Using them allows physicians to begin interventions before symptoms develop and prevent the disease from spreading. Universal routine testing also has the advantage of reducing the stigma associated with assessing high-risk behaviors. In contrast, high-risk testing often fails to capture large numbers of infected persons who do not see themselves as at risk or are unwilling to discuss their risky behaviors. A universal screening approach is preferable to the range of protocols currently in place from state to state. Some states use an opt-in approach, which requires that patients specifically consent to HIV testing. Several notable barriers limit the effectiveness of this approach. In addition to the informed consent, lengthy pre-test counseling is also required. Some physicians may not encourage testing to their patients robustly enough. Even with their physician's urging, women may not opt for testing because either they don't believe they are at risk or they fear the consequences of a positive test result. With uneven opt-in testing practices, many cases of HIV continue to be missed. The opt-out approach, on the other hand, notifies patients that an HIV test will be included in a standard battery of tests and procedures, but that they may refuse testing. This method yields higher testing rates and has been shown to be more cost-effective than risk assessment or opt-in approaches. However, the opt-out approach still hasn't been implemented in very many medical care settings. HIV testing among pregnant women and infants. Awareness of one's HIV status varies among new mothers. Some mothers know their status prior to their pregnancy. Others are diagnosed with HIV in prenatal care, while still others, particularly those with no prenatal care, are diagnosed after the baby is born. A primary strategy to prevent perinatal transmission is to maximize prenatal HIV testing of pregnant women and include voluntary testing as a routine component of both preconception and prenatal care. In the past, medical providers screened and tested only women who were at risk for HIV, thereby failing to diagnose women without established risk factors. To prevent this oversight and increase a woman's awareness of her HIV status prior to giving birth, the CDC now recommends that all pregnant women in the U.S. be screened for HIV infection using the opt-out approach. The CDC also recommends additional screening in the third trimester in settings with elevated rates of HIV infection. The informed consent procedure for pregnant women should include oral or written information about HIV infection, the risks and benefits of testing, and the significance of positive and negative test results. Initiation of appropriate antiretroviral treatment is recommended to women upon positive HIV test results. The child born to a pregnant woman with HIV should also be tested for HIV and treated with AZT for 6 weeks after birth. Because newborns receive maternal antibodies to protect them while developing their own immune systems, the HIV antibody tests most commonly used to diagnose HIV are not accurate in newborns. Direct testing for the HIV virus via PCR viral assay is the standard of care for newborns. Tests are generally performed at 2 weeks, 4 weeks, and 4 months. If the 2 and 4 week tests are negative, then the child is presumed to be uninfected. If the 4-month test is also negative, the child is considered definitely uninfected. Many clinics will also do an antibody test on the child after 1 year of age to be certain that the maternal HIV antibodies have cleared. HIV/AIDS symptoms and outcomes. HIV works to impair the human immune system, making people vulnerable to numerous life-threatening infections. Without treatment, HIV is almost universally fatal. HIV can have unique medical indications in women. For example, women with HIV often experience severe pelvic inflammatory disease, HPV infections, and persistent, frequent vaginal yeast infections. In addition, they tend to have higher rates of herpes simplex infections compared to the general population. Herpes can also make a person more susceptible to HIV and can make HIV-infected persons more infectious. Women with HIV are also at greater risk for certain cancers, especially cervical cancer, which is primarily caused by HPV. Rates of precancer genital lesions and cervical cancer are 4 to 5 times higher among HIV-infected women than non-infected women. Women with HIV who develop cervical cancer have poor immune system status and do not respond as well to antiretroviral therapy as HIV-infected women who do not develop cervical cancer. Infants and children with HIV exhibit their own constellation of medical symptoms and problems. They can suffer from weight loss, slower growth, damage to the brain and central nervous system, and heart, liver, or skin problems. Like infected adults, children are also much more susceptible to other ailments, including frequent bacterial infections, ear or sinus infections, and thrush, which is a yeast infection in the mouth or diaper area. Due to damage to the brain and central nervous system, children with HIV are also at risk of language, motor, and cognitive delays. Another study found that all infants exposed to HIV prenatally, even those who do not become infected, are at risk for developmental problems because of poverty, prenatal substance abuse, and maternal illness. Furthermore, infants of HIV-infected mothers who experience changes in their primary caregiver have lower motor and adaptive behavior scores. On the other hand, when children receive positive attention, they demonstrate better language, cognitive, motor, and adaptive scores. Unfortunately, some effects of HIV/AIDS may last into adolescence. Research shows high rates of psychiatric problems and learning disabilities among adolescents with perinatally acquired HIV. Medical treatment for HIV. There is no cure for HIV/AIDS, but highly active antiretroviral therapy, or HAART, can keep it in check. The goals of HIV treatment should be to improve immune system function and quality of life, and to prevent the spread of HIV. Effective HIV treatment can also prevent HIV from progressing to AIDS and reduce HIV-related mortality. Medications can help the infected person live a longer, healthier life, but they are less effective if they are not taken as prescribed. Unfortunately, adherence can be challenging because many of the medications can cause serious side effects until the body becomes used to them. Side effects can include nausea and vomiting, diarrhea, rash, insomnia, fatigue, psychiatric symptoms, and elevated cholesterol and triglyceride levels. Compared with adults, infants and young children infected with HIV have fewer medication options, and pediatric formulations of antiretroviral medications can be much more costly than their adult equivalents. Like in adults, treatment in children can cause unpleasant side effects, but it must be started before the child becomes vulnerable to potentially life-threatening illnesses. Further research is needed to standardize treatment protocols and improve and expand treatment for infants and children. HIV treatment during pregnancy. Unique issues and concerns arise in the treatment of HIV during pregnancy. For HIV-infected pregnant women, the CDC recommends the use of aggressive combination drug regimens that maximally suppress viral replication, including the incorporation of AZT to prevent perinatal transmission. Although a woman's health and the status of her HIV disease must be considered in treatment decisions, federal guidelines recommend restrictions on certain medications for pregnant women due to case reports of birth defects in infants of mothers who took these drugs during their first trimester. In addition, many other drugs available for non-pregnant women have not yet been tested in pregnant women and therefore can't be safely recommended. Medication adherence. Because of improvements in treatments and combination medications, many regimens have become simpler and easier to take, in some cases only 1 pill a day. For those just starting medications, the simplicity and effectiveness of treatment is a primary consideration. Patient adherence to the medication regimen remains a critical component of successful HIV treatment and AIDS prophylaxis. In fact, adherence has been found to predict long-term treatment success, whereas non-adherence is associated with viral resistance, which is more complicated to treat and requires much more medication. Depression and substance abuse are commonly cited as factors contributing to non-adherence to medication. Research has found that depressive symptoms, poor quality of life, and other psychosocial stressors reduce the likelihood that a woman will take her antiretroviral drugs as prescribed. Other prominent factors associated with non-adherence include fear of both short and long-term side effects, interactions with other drugs, and having little knowledge about HIV and treatment issues. Adolescents face additional barriers to adherence as they begin taking responsibility for their own medication regimens. Perceived social stigma, busy schedules, and body image issues that can arise from medication side effects may interfere with adherence. Furthermore, perinatally infected patients often face HIV drug resistance, a problem that emerges from their extensive treatment experience. This drug resistance may lead to a need for salvage therapy, which typically requires taking many pills twice a day, posing greater adherence challenges. In contrast, factors positively associated with adherence include knowledge about the importance of adherence, integration of treatment into the routine of everyday life, and social support for adherence. Thus, strategies to increase medication adherence include education about the importance of adherence for the prevention of HIV transmission, reminder systems such as beepers and pill boxes, regimen simplification, monitoring and addressing barriers to adherence, and tailoring solutions based on the unique challenges faced by individual patients. Next, we'll examine HIV/AIDS in a psychosocial context. Women and children living with HIV in the U.S. face various psychosocial challenges associated with the disease. Determining which of these issues predate the diagnosis and which are a consequence of the illness is difficult, but families affected by HIV face an array of complex and interrelated problems. Poverty. Common challenges confronting populations affected by HIV/AIDS include poverty, unemployment, poor housing, and lack of health insurance, child care, and transportation. In fact, the CDC finds that heterosexuals living below the poverty line in U.S. cities are 5 times as likely as the general population to be HIV positive. Factors contributing to this relationship include limited health care access, which reduces utilization of HIV testing and prevention services, substance abuse, which increases sexual risk behavior, and high incarceration rates, which disrupt the stability of relationships. Not only are poorer people more vulnerable to HIV/AIDS, the disease puts them at risk of becoming poor due to job loss or exorbitant health care costs. Women living with HIV tend to be poorer than their male counterparts. Not coincidentally, children infected by HIV are also likely to live in poverty and with a single parent. Social and economic concerns are particularly important to families affected by HIV/AIDS because low income, lack of private insurance, unemployment, and low education level are predictors of poorer health and barriers to accessing needed health care. Moreover, HIV-infected women of low socioeconomic status are frequently exposed to high levels of violence and experience a poorer quality of life than those who are more affluent. Intimate partner violence and childhood abuse history. Intimate partner violence is another complex problem that affects many women with or at risk for HIV. Several relationships exist between partner violence and HIV. Childhood physical and sexual abuse may lead to later sexual risk-taking behaviors. Sexual violence heightens HIV risk, and disclosure of an HIV-positive diagnosis may be a precursor to partner violence. Specifically, experiencing childhood abuse is related to early sexual initiation, sex with unfamiliar partners, and low rates of condom use among women with HIV. This is partly due to the adverse impact childhood abuse can have on a developing girl's physical, mental, and sexual self-image. As women, childhood abuse victims may feel powerless in their sexual relationships and have difficulty forming lasting relationships with men. Consequently, they may engage in sexual relations with multiple partners or consent to high-risk sexual behavior to obtain comfort or attention. In addition, research has found that post-traumatic stress disorder resulting from partner violence is strongly correlated with high-risk sexual behavior, including having unprotected sex with a partner who is an injection drug user or who is known to be HIV positive. Such risky behavior may result from being coerced or forced into sex, or maybe because a woman fears her partner will retaliate with violence if she requests the use of protection. Women who are pregnant and HIV positive are particularly vulnerable to violence. Although most partners respond to a woman's disclosure of her HIV diagnosis with sympathy and understanding, between 3 and 15% of women who disclose their diagnosis report that their partner responded with anger, blame, abandonment, and violence. Most pregnant women exposed to violence have had a prior history of partner violence, but a significant minority report that it worsened during pregnancy. Over 90% of pregnant women who experience partner violence are abused by the biological father of the unborn child, and between 25 and 50% of those abused in pregnancy are kicked or punched in the abdomen. Additional factors that are associated with HIV and may contribute to pregnant women's exposure to violence include poverty, drug use, and bartering sex. Mental health issues. Mental health issues are prevalent among people with HIV infection, especially women. Studies have found that women with HIV infection tend to have more depressive symptoms than HIV-negative women, and twice the depression rates as HIV-positive men. Ethnic differences are also seen, with higher rates of depression among HIV-infected African American women than with their white counterparts. A woman newly diagnosed with HIV is likely to experience concerns about her health, her ability to manage her illness, her life expectancy, and the stability and well-being of her family. She may react to her testing results with a variety of emotions, including numbness, anxiety, fear, anger, and denial. She may fear the potential loss of her ability to bear children, the loss of relationships, and/or dying from her illness. A woman who has just learned of her diagnosis may also be angry with the person or persons who transmitted the infection to her, or with her medical provider for being unable to predict her future outcome. Other women may respond with anger, not at their partners or providers, but at the government. Nearly 1 out of 4 African Americans in one study believe that the federal government engineered the virus to eradicate their community. For some women, the negative emotions experienced upon learning of their infection may trigger serious mental health or substance abuse disorders, or compound already existing mental health problems. Women can also respond to the diagnosis with denial, which may serve as a barrier to seeking treatment or taking steps to prevent the spread of the disease. The perinatal period often brings intensified distress for HIV-infected women. Childbirth may be the occasion when a woman first learns of her diagnosis. The trauma of this discovery may be heightened by her fear that she has transmitted the infection to her infant. Women who have other children may also worry they will be abandoned or abused if she dies, or that they will be taken away by Child Protective Services. Despite declines in the last 20 years in the suicide rate among HIV-infected persons, the number of infected individuals who take their own life remains more than 3 times higher than in the general population. Feelings of hopelessness and untreated mental illness among persons with HIV likely contribute to this elevated suicide rate. It is critical, therefore, for women who test positive for HIV to receive immediate counseling and support to help them understand and cope with their new status and circumstances. Children in the family also experience a range of emotions by virtue of the presence of HIV in the household, and specifically with their mother. Children affected by HIV and AIDS are more vulnerable and face greater challenges to their psychosocial well-being compared to other children of the same age. These challenges include the ability to cope with the illness or death of a parent, the resilience to deal with challenges specific to their situation, and the possession of social, emotional, motor, and cognitive skills appropriate for their age and developmental state to fully participate as members of society now and in the future. Many of the children have numerous fears and anxieties. One recent study, for example, found that 2/3 of family members, including minor children, experience fears about HIV transmission in their home with an HIV-infected parent. Substance use. Substance use disorders are a significant problem among many women with HIV/AIDS. While the proportion of women who contract HIV as a result of intravenous drug use is 50% lower than a decade ago, an estimated 15% of new HIV diagnoses for women are related to injection drug use. Women who abuse drugs also participate in other risky behaviors, such as trading sex for drugs or money, or engaging in high-risk sexual behavior due to impaired judgment associated with drug intoxication. In addition, nearly 20% of women living with HIV drink excessively, defined as a history of drinking 4 or more alcoholic drinks per day or 7 or more alcoholic drinks per week. Excessive drinking is associated with depression or unemployment, co-infection with the hepatitis C virus, and lack of high school graduation. HIV-infected women with co-occurring substance use disorders face additional challenges surrounding HIV/AIDS care and treatment. They are less likely to use medications prescribed for their HIV infection, they confront more barriers to treatment, and they experience poorer HIV-related health outcomes than HIV-infected women without substance abuse. Furthermore, serious interactions between recreational drugs and antiretroviral drugs have occurred that render the antiretroviral drugs ineffective or increase the level of recreational drugs in the system to fatal levels. Stigma, discrimination, and HIV disclosure. Societal and cultural stigmas against persons with HIV/AIDS continue to abound and negatively impact the daily lives of infected persons. One survey found that 38% of infected persons feel that others judge them on the basis of their HIV status, and almost half reported that people avoid even casual contact with them, such as sharing food or drink, due to their infection. Not surprisingly, as perceived stigma increases, people become less likely to disclose their status. Many HIV-infected individuals have voiced concerns about others learning their HIV status and the impact disclosure would have on their current or future relationships, reputation, or employment status. Reasons women give for avoiding disclosure include fear of abandonment, rejection or discrimination, or upsetting family members. In part because of the stigma and discrimination experienced, many people with HIV feel socially isolated. People with HIV/AIDS experience more social rejection and isolation than cancer patients, and women, particularly African American women, appear most affected. Some scholars suggest that this difference is due to the multiple layers of stigma that women and minorities with HIV/AIDS face. Indeed, studies have shown that African Americans are less likely to disclose their status to family and friends than whites. Stigma can also negatively impact the children of mothers with HIV. Children who perceive stigma associated with their mother's HIV status have been shown to be more likely to engage in externalizing behaviors, including bullying and physical violence. Stigma surrounding the disease may also discourage children from reaching out for social support, and it may damage their feelings of self-worth. To help protect children with HIV from such stigma, some parents delay disclosing their own status, or the child's diagnosis, or treat it with secrecy. Unfortunately, wrapping the disease in secrecy can actually increase the stigma attached to it. Experts argue that 3 common misconceptions about HIV must be addressed to reduce this stigma. These misconceptions include beliefs that all people with HIV engage in risky behavior, that people with HIV or AIDS should be avoided, and that HIV is easily transmitted through casual contact. Addressing such stigma is critical, as it may contribute to depression, anxiety, alcohol and other substance use, risky sexual behavior, and poorer medical outcomes among women with HIV. Deciding whether and to whom to disclose their HIV status is an important issue persons with HIV must consider. Some scholars have described the disclosure process for HIV-infected individuals within a 6-step framework, with various decisions and challenges faced at each step. In the first step, the person living with HIV must adjust to her diagnosis and begin to accept it. Next, she should evaluate whether she has the skills to disclose her diagnosis to others. Third, she identifies those in her social network whom she might tell, considering the appropriateness of disclosing to each person. Next, she assesses whether the circumstances are conducive to disclosure in each case. She then anticipates the reactions of each recipient, determining if the potential benefits of disclosure outweigh any possible negative repercussions. Finally, she identifies her motivation for disclosure to each person. Through this framework, disclosure is seen as a process rather than a definite outcome, and experts emphasize that women need emotional support throughout. Despite the named barriers, women are more likely than men to disclose, and having a strong social support network can help women have the confidence to disclose. Fortunately, reactions from others to the disclosure are usually more positive than anticipated. For example, disclosure can elicit emotional support and strengthen relationships. Disclosure to a sexual partner may motivate him to be tested, seek necessary medical treatment, or alter his behavior to decrease the transmission of HIV. Disclosure can also improve a woman's health more directly because women who disclose are more likely to obtain HIV-related services. A mother's disclosure of her diagnosis to her children can be particularly important to address, as it may affect child adjustment and the mother-child relationship. The decision to disclose to children involves weighing the pros and cons of disclosing, and is often based on the child's perceived ability to handle the information without being psychologically harmed. One study found that approximately half of the children of HIV-infected mothers reacted in a primarily positive manner to disclosure, while about 40% reacted negatively, the latter expressing fear, anger, or rejection. Mothers may choose not to disclose to their children to avoid their negative responses, but research shows children are better adjusted overall when they are aware of their mother's HIV status. If not informed, they may intuitively know something is wrong with their mother, or notice her taking medications and feel anxiety or confusion if they don't know why. Open, honest communication between parents and children can facilitate positive experiences with disclosure and allow children an opportunity to grieve and clarify any misconceptions they may have regarding HIV. Grief and loss. Despite advances in HIV treatment and a reduction in AIDS-related deaths, persons with HIV continue to lose loved ones to AIDS. Grief may be particularly complicated for survivors with HIV because their loved ones did not respond to treatment as successfully as they have. Both depression and traumatic stress are reported symptoms associated with AIDS-related bereavement among women as well as men. Severity of grief is elevated when the loved one is very close to the bereaved, when the bereaved has an existing substance use or mental health problem, and when he or she has little informal or formal social support. Bereaved women are particularly concerned about loss and coping issues related to their children, deceased partners, or spouses, and stress related to family responsibilities and caregiving. Children with HIV also must deal with grief as many lose one or both parents to AIDS. Although children may be provided for materially upon the death of a parent, their psychosocial needs may be overlooked. Grief over the loss of a parent may encompass cognitive, physical, emotional, behavioral, spiritual, and social difficulties. In response to the death, young people may display behavioral regression and require more attention from adults. When facing their own death, HIV-infected children can experience great fear and a loss of control, becoming withdrawn or irritable. They need support to understand and cope with the impending event and often benefit from playing a role in making decisions affecting their lives. Let's look at the issue of HIV/AIDS in a parenting context. Mothers who learn of their HIV status during their pregnancy or upon the birth of their child often find the experience traumatic. Discovery of their HIV status often leads to depression, particularly if the child turns out to be HIV infected. Depression has been shown to have a direct impact on women's daily functioning, including child rearing. Research has indicated that women's depression is associated with being less able to perform typical mothering tasks. Depressed mothers tend to be less attentive and protective toward their infants, have fewer positive interactions with their children, and provide a lower quality of environment. Indeed, a review of 9 published studies found that depressed mothers were less affectionate and verbally responsive to their young infants, and where negative or diminished maternal affect was present, the infant responded with similarly altered affect. These infants are at risk for attachment problems. In general, depression and life stress in mothers with HIV predicts poorer family cohesion and interferes with effective parenting and child well-being. Poor maternal coping often leads to child maladjustment. Research has established that children may be forced to assume caretaking roles because of their mother's illness, leading to more absences from school, lowered school performance, and overall distress. Nevertheless, this parentification of young children also predicts greater autonomy in adolescence, particularly when the child has a close attachment to the mother and good coping skills. Research has demonstrated that a number of factors, parents' ethnicity, socioeconomic status, health status, mental health, parenting stress, parental coping, and parenting skills, disclosure of HIV status, social support, and perceived HIV-related stigma can all affect a child's coping skills, self-concept, autonomy, social relationships, mental health, and behavioral and social adjustment. Among other findings, these studies demonstrate that children have fewer depressive symptoms and higher levels of satisfaction when their mothers are physically healthy. Several parenting factors also promote positive child outcomes. For instance, parenting skills, including parental monitoring and creating family routines, can foster child resilience. These parenting skills, especially parental monitoring, can also help prevent adolescents from engaging in risky sexual behavior, thereby protecting them from contracting or spreading HIV. Now we'll look at HIV/AIDS in a legal context. HIV-infected mothers often grapple with how their medical condition impacts their current and future ability to provide care for their children. A mother may choose to appoint another adult to assume custody and care for her child or children in the event that she becomes too ill or dies as a result of her condition. In select states, she may also designate a standby guardian who has authority over the child once the parent is no longer able to provide the caretaking. Appointing a standby or legal guardian usually requires a written petition and a court hearing. Even when a standby guardian is designated, the parent shares in decision-making for the child until he or she becomes incapacitated. Upon the triggering event, the standby guardian applies for permanent guardianship. Making custody and care plans gives parents the power to determine who will care for their children and can alleviate stress and worry. But workers should never force clients to develop a care plan. Permanency planning may require a mother to disclose her status to other adults, which she may be uncomfortable doing. She may worry that her disclosure may be shared in open court, putting her at risk of losing her job, housing, or insurance. Custody planning may also require notification of the child's other parent, A woman may fear this notification will lead to violence, resistance, or retaliation from the other parent. It also forces her to face her own mortality directly. Because of these potential concerns, workers should inform clients of their options and allow them to begin the permanency planning process on their own terms. Some families affected by HIV may have legal needs outside of guardianship and custody issues. These may include cases of discrimination in hiring, wages, or housing. Women may also need assistance in applying for public benefits or appealing these decisions, or addressing issues related to immigration, political asylum, suspension of deportation, and naturalization. In 2009, Congress voted to remove the ban on HIV-infected non-citizens becoming residents. Women with HIV may also need legal representation to deal with breaches of confidentiality. Providers must consider and respect a woman's right to privacy and confidentiality at all times. Her HIV status must be protected throughout the course of her treatment. This protection of privacy shows respect and enhances trust between client and provider. Nevertheless, providers have the right, though not a duty, to inform persons who may be exposed to HIV. Before acting upon this right, however, a provider should counsel the client to take responsibility for disclosing her infection to those she may be putting at risk. Certain situations may also arise in which the woman must disclose her diagnosis in order to receive services. For example, AIDS service organizations may require a copy of the diagnosis, or disclosure may be needed to qualify for services, such as special housing or social services. On the other hand, there is no need for most people to reveal their HIV status in the workplace. If the disease happens to interfere with workplace productivity, an employee may notify a supervisor that she has a disabling condition. She is then protected by the federal Americans with Disabilities Act from discrimination and may be offered reasonable accommodations to continue working. The Ticket to Work and Work Incentives Improvement Act, enacted in 1999, also contains provisions important to those unemployed and disabled individuals with HIV/AIDS who are contemplating workforce re-entry. Many areas in the country have legal resources specifically for persons with HIV/AIDS. These services are often low cost or free for persons demonstrating financial need. Services may include helping individuals with the type of issues we've been discussing. Now we will discuss interventions targeting pregnant women with HIV. Care for pregnant women should include services to address their medical, psychological, social, and practical needs. In order to reduce mother-to-child transmission of HIV, the Association of Maternal and Child Health Programs recommends the availability of early prenatal care and coordinated clinical care, counseling, and support for HIV-infected women. Each woman should be monitored by an obstetrician-gynecologist and an HIV specialist throughout her pregnancy. In complicated obstetric cases, maternal-fetal medical specialists may need to be consulted. In addition, social workers can help a woman find food, housing, or child care, or apply for public benefits. Depending on her situation, a woman may also need referrals for parenting classes, legal or domestic violence services, or substance abuse and detoxification programs. Let's look at interventions to assist women with HIV and their families. Research suggests that effective interventions with HIV-infected mothers and their families promote positive parenting and problem-solving skills, address the numerous stressors they face, and help them build social support to cope with their illness and motherhood. No one program or profession can provide the breadth of services required by these families. Multidisciplinary treatment teams are essential to address the diverse needs of families affected by HIV/AIDS, from medical and behavioral health to social support, developmental services, and legal assistance. Interdisciplinary and multi-agency collaboration happens at many junctures in service provision, in clinical practice, on home visits, in clinics, and at care planning conferences. Culturally relevant services. As with any effective social work intervention, particular attention must be paid to cultural issues in addressing services for families affected by HIV/AIDS. This subject is vast, therefore we can only touch upon some general themes in this training and offer a caveat that the statements to follow are broad generalizations and not universally applicable. Programs that offer multicultural staff, bilingual client materials, therapeutic approaches, and curricula that are respectful and accepted locally, staff training on cultural sensitivity, and services offered in partnership with clients are most likely to be culturally appropriate. Let's review what we know about two populations disproportionately impacted by HIV/AIDS. Interventions with a family focus rather than an individual focus are often the most appropriate option for African American mothers and may ease psychological distress and family-related disputes. Interventions should also draw upon the strength of a woman's social network and bolster ethnic pride and positive self-esteem. These social networks, including extended family, community members, and friends, often serve as a powerful source of support for women. Strategies should empower African American women and their families to make their own choices in an effort to restore self-efficacy and self-esteem. Integrating faith and spirituality into interventions is also an important component for many African Americans. HIV/AIDS often carries a profound stigma in Latino culture. Women with HIV are reluctant to disclose their HIV status for a number of reasons, including fear that they will be perceived as promiscuous or substance users, fear of intimate partner violence, and perceived threat of deportation. Programs serving Latinas should adopt service strategies that reflect universal Latino cultural values and beliefs, such as honoring the family. They should also provide help in coping with perceived stigma, address traditional cultural beliefs that pose barriers to disclosure, and counteract mothers' beliefs that they have not lived up to the archetype of ideal motherhood. Family-based interventions. Family-centered approaches are commonly accepted as the most suitable, effective models for services to families affected by HIV. Given the social, economic, and psychological challenges faced by families living with HIV infection and AIDS, it is important to provide services that address these issues and nurture the relationship between mothers and families living with HIV/AIDS. Home-based services are valued because they sidestep common barriers to services, namely child care, transportation, and finances for families. And they provide an accurate portrayal of household and family dynamics. Home visiting allows providers to meet and accept the family where they are, literally. Key to the work is a long-term, trusting, non-judgmental relationship between the family and service providers. While families affected by HIV/AIDS often confront significant and prolonged difficulties, many also have protective factors that may be tapped to improve their psychological, social, and health outcomes. For example, pregnant women with HIV/AIDS may view childbirth as an opportunity to adopt a healthier lifestyle. This may also be the moment when a woman finally accepts professional help to manage her illness and make positive changes. Some families will develop strong social ties with other families who are impacted by HIV/AIDS. These alliances can offer support, resources, and help. To optimize care, HIV/AIDS providers should be aware of and build upon the strengths families bring to treatment. Interventions should be developed in partnership with and reflect the specialized needs and circumstances of the client families. Rather than prescribing goals and enforcing them, staff members need to support clients to set and reach their own goals. Interventions with families often begin with a period of comprehensive assessments. Examples include infant and child development evaluations, risk identification, mental health assessments, social support and parenting scales, and community needs and gaps assessments. This thorough assessment process solicits a family's perspectives and informs family-centered goal setting, which is the core of the intervention. Case management, or case coordination, works as a powerful therapeutic tool in programs. Staff members assist families in identifying their needs, developing goals, and obtaining services. Thereafter, they rely upon the support of the interdisciplinary team to access or provide the full array of services that the family needs. Although providers are committed to their work with family units, they should never lose sight that these efforts support the child's development, well-being, and safety. It is critical that everyone on the team assume responsibility for ongoing monitoring of the child or children and address any potential risk factors that hinder a child's growth and development. Individual counseling. Several therapeutic techniques have been shown to help persons infected with HIV successfully cope with their illness. Cognitive behavioral therapy can help with countering dysfunctional thoughts, improving mood, changing self-destructive behaviors, and improving medication adherence. Motivational interviewing is another method that can be used to reduce risky behavior. This approach consists of individual counseling sessions in which the woman identifies episodes of risky behavior, such as substance use and unprotected sexual activity, assesses her readiness to reduce these behaviors, and discusses her ambivalence about behavior change. Some research indicates that combining motivational interviewing with cognitive behavioral therapy is a particularly effective treatment for HIV-infected adults with substance use disorders. In general, counselors should collaborate with other mental health and medical providers, provide risk reduction strategies to minimize the spread of HIV, and harm reduction counseling to substance abusers. Ensure a client's concrete needs are met. Prepare the client for the possibility of disability, death, and dying. And educate significant others about how to care for and support the client. The counselor may also normalize the client's emotions, teach healthy coping strategies, and encourage the use of friends and family as supports. Support groups and group counseling. Group counseling for women and adolescents with HIV/AIDS can be helpful in treating depression, reducing social isolation, increasing coping resources, and obtaining support. People often feel relief when they learn that others have had the same experiences. Listening to others' challenges can offer a woman a better perspective on her own problems and help her learn new ways to cope with her illness. One successful women's group focused on exploring views of the self, learning to identify and express feelings, trying new behaviors, identifying life goals and values, discovering strengths, and developing interpersonal skills and relationships. Group therapy has also been shown to improve mood, relationships, and medical outcomes. Group interventions that utilize cognitive behavioral approaches have been successful in improving mental health outcomes for women. These groups help with developing social support, identifying and expressing emotions related to loss, identifying coping challenges accompanying the loss, recognizing stressors, setting goals for coping with the loss, and developing adaptive coping skills to reduce psychological distress. Women participating in such groups demonstrate greater improvement on measures of anxiety, depression, and grief. Substance abuse assessment and treatment. The pronounced link between substance use and HIV/AIDS has prompted some experts to recommend screening patients for drug use at the initial HIV diagnosis and at least annually thereafter. Screenings should inquire about the most commonly used recreational drugs, be tailored to and adjusted for the client's substance use history, and be conducted in a non-judgmental manner. Preventing HIV transmission among those with substance use disorders involves treating users with respect, educating them about how they can change their behavior to reduce transmission, and providing them with the means for change, including access to clean needles, condoms, and drug abuse treatment. Community-based outreach, peer-based interventions, skills building, and individual and group counseling are among the approaches that may successfully reduce the risk of HIV transmission among substance-using populations. Federal programs and services. The federal government has made a long-standing commitment to assist families affected by HIV and AIDS in the United States. The Ryan White Comprehensive AIDS Resources Emergency, or CARE Act of 1990, established a program that helps provide care for people with HIV/AIDS. After Medicare and Medicaid, it is the largest source of public financing for HIV/AIDS care. The Act is divided into several parts, including Part D, previously called Title IV, through which a comprehensive care system has been developed for women, infants, children, youth, and their families. Research has demonstrated the effectiveness of this comprehensive and coordinated approach in delivering HIV treatment. Since 1990, the Children's Bureau of the U.S. Department of Health and Human Services has provided grant funding under the Abandoned Infants Assistance, or AIA program, to support service projects working with families affected by HIV/AIDS. AIA projects have found that the most effective services for these families are family-centered, culturally based, comprehensive and coordinated, individualized, strength-based, solution-focused, and flexible. In addition to Ryan White and AIA, various federal agencies conduct HIV/AIDS-related research, prevention, and intervention activities. For example, the National Institutes of Health conducts research in a variety of HIV-related areas, including etiology, therapeutics, vaccines, behavioral interventions, and the impact of HIV/AIDS on specific populations. The Substance Abuse and Mental Health Services Administration studies how substance abuse influences the spread of HIV and aims to increase access to HIV prevention, care, and treatment. It is also being called on to ensure routine HIV testing is offered at substance abuse and mental health treatment centers. Finally, in addition to its surveillance activities, the CDC collaborates with state and local partners to conduct prevention research and develop, implement, and evaluate evidence-based HIV prevention programs. While these federal agencies provide important HIV/AIDS-related services, the White House has established clear goals for improving the national response to the HIV/AIDS epidemic. In July 2010, the White House's Office of National AIDS Policy released its National HIV/AIDS Strategy, which outlines 3 primary goals. 1. Reduce the number of people who become infected with HIV. 2. Increase access to care and optimize health outcomes for people living with HIV. And 3. Reduce HIV-related health disparities. The President called upon the various agencies and organizations involved in the fight against HIV/AIDS to undertake a more coordinated effort so that, in his words, the United States will become a place where new HIV infections are rare, and when they do occur, every person will have unfettered access to high-quality, life-extending care, free from stigma and discrimination. Conclusion. HIV continues to be a significant problem affecting women and children in the U.S., particularly African American and Hispanic families. More women and children are living with HIV today than at any time since the beginning of the epidemic, and they require long-term and complicated medical care and treatments. In addition to coping with a chronic and life-threatening illness, HIV-affected families often face an array of other complex problems, including poverty, inadequate housing, depression, substance abuse, violence, and future care and custody planning, and they continue to need comprehensive services to effectively address these issues. A one-size-fits-all approach will not be sufficient to curb the spread of HIV/AIDS among women and children. Further research must be sponsored and conducted to ensure that services provided to HIV-affected families are evidence-informed. To effectively address racial and gender disparities, HIV prevention and intervention efforts should take into account the myriad factors these women and children face on both an individual and societal level.